You have meningitis. That's how I knew I was having a bad week, but not as bad as the patient I said that to. So, welcome back to my channel where I talk about cases that I had in the emergency room this week. It's going to be a great episode. We're going to talk about that case of meningitis that I saw this week. We're going to do an infectious update, and we're going to talk about a kid who came in with chest pain that had something you might not expect. As always, thanks again for clicking on this video. My name's Dr. Eli. I am a board-certified pediatric emergency medicine doctor. I work clinically in a local ER. I see over 3,000 patients a year, and my hope is to share some of my best stories from my last week in the ER with you. All right, so let's jump right into the infectious update this week. This week, we've been seeing a spike of a virus that I haven't seen in months called Human Metapneumovirus. Now, chances are you've probably never heard of that virus before. It's not one of those common viruses that we talk about all the time, but it's a heavy hitter and it's good to know about. Human metapneumovirus was only recently discovered as far as viruses go. In fact, it was only named formally in 2001. And since then, it's become a really common cause and reason that children come to the emergency room. It's part of a family of viruses called the Pneumoviridae family of viruses. And while that name probably won't mean a lot to you, this one might. It's related to RSV, or respiratory syncytial virus. And anyone who has children, or anyone who has ever been to an emergency room, is probably familiar with that virus, RSV, or respiratory syncytial virus. It's a really common virus that we see in the fall and winter months, and it causes this really bad junky cough, and in younger kids can cause a lot of trouble breathing. Well, the cousin of that virus, this one, the human metapneumovirus, does the same thing. It's really common in the warmer months, unlike RSV, so we tend to see it at the end of the spring, maybe summer, early fall, and it causes that same junky cough, bad cold symptoms, and you might guess because of its name, human metapneumovirus, it causes a lot of pneumonia. And I see a lot of children coming into the ER with pneumonia symptoms because of this virus, hMPV. What's difficult about hMPV is that it can be hard on chest x-ray when you're diagnosing pneumonia to know whether a child actually has a viral pneumonia or a bacterial pneumonia. All we know is that children come into the emergency room with fever, cough, trouble breathing, low oxygen, and when I listen to their lungs, the lungs sound wet and crackly. But that doesn't tell me if it's a virus that causes it or a bacteria that causes it. So realistically, we treat it the same. This virus can be pretty rough though. For all the children admitted to the hospital for acute respiratory infections, this virus has been isolated in up to 10% of cases, which is wildly high given how many things can cause respiratory symptoms and infection in children. The fact that 10% of children are getting admitted with this just goes to show you how dangerous a virus it is. And to make it worse, like RSV, its cousin, there's no treatment for it. All we can do is keep children safe, monitor their oxygen levels and their vital signs, give extra oxygen if they need. In the worst cases, we sometimes have to escalate respiratory needs, which means extra supplemental oxygen, high flow oxygen, CPAP, or God forbid, a ventilator to make sure that these children are safe while their body fights off the virus on their own. If a young child that you know develops a cough that's loose, that's junky, they start having trouble breathing, and maybe even sounds like an RSV infection that they might have had in the fall, think about this new virus, newish virus, human metapneumovirus, that actually causes a lot of bad respiratory infections this time of year. The other weird thing that we've been seeing this week from an infectious update is I've been seeing a small spike of COVID-19. I hadn't seen COVID in probably weeks or months at this point, and yet over my last couple shifts, I think I've seen 6 or 8 cases of COVID-19 in the ER. And these patients are coming in with the typical symptoms: fever, cough, runny nose, congestion, fatigue, muscle aches, poor appetite. But it's surprising people because we just got through this really bad flu season, and thankfully flu cases are way down. I don't think I've seen a flu case in the ER in over a week at this point. But for whatever reason, these COVID-19 cases are back, and it's really throwing people off. Now, I said this in a previous video. The good news is whatever strain of COVID-19 is currently out there, in my experience, which is anecdotal, doesn't seem to be that bad at this point. I haven't admitted a single young patient to the hospital with COVID-19 in months. So although we have been seeing the spike of COVID-19, at least I've been seeing the spike of COVID-19 over the last couple weeks, my hope is that it stays mild and doesn't become this full-blown epidemic again that we saw in the last year. All right, now you probably clicked on this video because of meningitis. So let's talk a little bit about this meningitis case that I had. It was a weird presentation because The case occurred in an 18-year-old young man who came into the emergency room actually before I even saw him the first time 2 days earlier because he was having typical norovirus type symptoms. He was having fever, poor appetite, nausea, vomiting, diarrhea, and he came into the emergency room worried he might have appendicitis, gas pain, who knows, some other belly infection, and was seen by one of my colleagues. He had this huge workup. He had blood work, IV fluids, CAT scan of his belly, all of which reassuringly ended up looking okay. His blood counts weren't very elevated, his electrolytes were okay, and the CAT scan didn't show any appendicitis. So he was diagnosed with something called gastritis. And gastritis is what we typically think of as inflammation or infection of the stomach. So this patient was diagnosed with probable infection of his stomach because that's all that was left after all the testing came back reassuring. He was sent home on an acid blocker, which is very common, and then discharged. And what happened to this unfortunate young man over the next 2 days is his symptoms changed. And they changed from belly pain, nausea, vomiting, diarrhea to headache, visual disturbances. He started having blurry vision, light sensitivity, and then his neck got stiff. And that's when they got scared. Now, of course, fever, headache, neck stiffness, the combination of those three should always be an alarm system for everyone. When people come into the emergency room with fever, headache, and neck stiffness, that doesn't mean you have meningitis. In fact, in my experience, most people who come into the ER with fever, headache, and neck stiffness have some kind of tonsillar infection, like strep throat, or maybe they have a deeper neck space infection, like an abscess, either next to their tonsil or behind their throat. But the risk of meningitis is still rare. That being said, if you have headache, high fever, and neck pain, please go see a medical professional so you can be evaluated. Now, unlike their first visit to the emergency room where they came in with belly pain, vomiting, diarrhea, this time the patient came in and was sitting up in bed like this. They literally could not move their neck to either side, up or down. When I asked him to raise his chin to look up at the ceiling, he literally almost cried from the pain. And when I asked him to touch his chin to his chest, he literally could not. He could not move his neck down. That's how stiff the back of his neck was. And anytime he tried to move, he had this blinding pain in the back of his neck, in the back of his head. And that was when I looked at him and I said, I'm really sorry to say this, dude, but you have meningitis, which is never a good day for a patient. And frankly, not a good day for us either, because that's not what we want to tell people. And I rightly freaked the crap out of his mom and the patient. Now, the good news is because this patient had been sick for a couple days, and because when they came into the ER, they were uncomfortable, but didn't look like they were acutely dying that minute, I had a hunch that this was actually something called aseptic meningitis or viral meningitis. Like many things that we see in the emergency room, infections can be, of course, viral. They can be bacterial. Of course, those are not the only two causes of infections. There are many other things that can cause infection. But as an emergency room doctor, I'm often asking myself, is this a viral infection or is this a bacterial infection? The good news is I had a pretty good idea that this child did not have bacterial meningitis. First thing is that he'd been sick for multiple days and wasn't dead. Bacterial meningitis is a fulminant infection, meaning that it gets bad and it gets bad fast. So when these patients come into the emergency room, if they come in early, they can look okay, but over the course of hours, they can look critically sick. And while viral meningitis and bacterial meningitis can look relatively similar, or rather have similar symptoms, bacterial meningitis tends to be much worse. You see higher fevers, you see worse headache, worse neck stiffness. And frankly, you can also see what's called a petechial rash, which are these red spots or these red patches, if you see purpura, on your skin. And what it means when we say petechial or purpuric is when you tug on that red part of your skin, or hopefully someone else's skin, the redness doesn't go away. They're non-blanching, which is a sign to us that there could be something like bacterial meningitis going on. It's a huge red flag. The other hint is that aseptic meningitis, or in this case, what ended up being enteroviral meningitis, and I'll talk about that in a second, tends to have a seasonality to it. And what that means is that these infections tend to occur in the warmer months, late spring, summer, early fall. So this really was the perfect time for it. And the last hint that I had that this was probably viral meningitis was the patient came in after having typical viral symptoms for the last 48 hours. In fact, the virus that I was suspicious of, like I said a minute ago, is something called enteroviral meningitis. Enterovirus is a virus. Entero, meaning digestive, is a virus that typically causes digestive type symptoms. So yes, you can see high fevers, but you also see sore throat, poor appetite, nausea, vomiting, diarrhea, and that's what this patient came in with the first time. In fact, that's almost certainly what they had the first time. This patient probably had 2 days before I saw them, when my colleague saw them, enteroviral gastritis. Unfortunately, this patient got really unlucky and over the subsequent 48 hours started developing full-blown aseptic meningitis. And when I saw him in the emergency room, that is what I diagnosed him with. What's tricky about viral meningitis is that no matter the cause of meningitis, the patient needs a spinal tap, which, yes, does mean taking a needle and putting it into the small of their back in order to collect what's called CSF, or cerebral spinal fluid, around the spinal cord. This guy was not super jazzed about the idea of having a needle put into the small of his back, but realistically, it is our only definitive way to diagnose meningitis in the emergency room. It's also important because although I had a hunch that this was viral meningitis, you kind of have to prove it, right? If he had bacterial meningitis and I didn't put him on strong, broad, multiple antibiotics immediately, he could die. So it's kind of important for us to be sure in that moment that no matter what I think is likely true, we cross our T's, dot our I's, and make sure of it. So this patient did undergo a spinal tap in the emergency room. Thankfully, it did come back as positive for enteroviral meningitis, like I thought. However, we're still safe, and the patient was still admitted to the emergency room. No, not the ER. The patient was still admitted to the hospital on double broad antibiotics, in this case, ceftriaxone and vancomycin, in order to cover any common cause of bacterial meningitis until we knew that that cerebral spinal fluid that we got from his back and sent to the lab didn't grow any bacteria over multiple days. Only then were the antibiotics peeled off, and the patient was eventually discharged home to recover at home. Because similarly to many other viral infections, there's no cure for enteroviral aseptic meningitis. It's pain control, supportive care, and letting your body do what it does best, which is fight off infection and heal. I wish that enteroviral meningitis was the only complication of a common viral infection that I saw in the ER this week, but actually I saw something potentially, believe it or not, even scarier in this last patient. So I had a 16-year-old young woman come into the emergency room with chest pain. This is an everyday occurrence for us. Chest pain, especially in the pediatric and adolescent population, is an extremely common reason why people come into the ER. Why wouldn't you? If you have pains in your chest, which is where your heart is, and you're worried that something might be wrong, you're going to come into the ER. Even if you called your primary doctor and said, hey, I'm having chest pains, will you see me? They're going to tell you, go into the ER. You need to be seen to make sure this isn't something dangerous. Like many young adolescents who come into the emergency room with chest pain, I'll be honest with you, my initial concern about her was relatively low because it's so unlikely that she's having a true heart attack at that age with no other medical problems. We often have time to figure out exactly what's going on. Is she having some muscle pain from the sports that she's playing? Is she having heartburn from the coffee or the spicy food that she's drinking? Is she having pneumonia or some other respiratory infection? There are many things that can cause chest pain that thankfully aren't that dangerous in this population, and we typically go through them systematically just to make sure that patients are okay. So before I even saw this patient for the first time, she goes into the triage booth where a nurse takes the story of why you came into the ER, and then they did something called an electrocardiogram. Many of you have probably had an electrocardiogram, ECG, sometimes called EKGs as well. They put lots of stickers on your chest, and then it prints out this funky looking picture that shows us the tracing of your heart rhythm. And that right off the bat gives us an idea, how at risk are you for having a heart attack, or is there some other abnormality in how the electricity is moving through your heart? Her electrocardiogram was brought back to me, as any EKG, ECG is immediately read by a physician to make sure that there's nothing emergent going on. And it was normal. And I said, this is great. I put it down on my desk and she went back to the waiting room. About an hour later, when it was her turn, as it goes in emergency rooms, she came back into the exam room and then started telling me her story herself. And right away, there was something about this that I didn't love. The first thing I noticed is that while on her ECG that I had seen earlier, her heart rate had been normal, somewhere in the mid 80s beats per minute, by the time I had seen her, her heart rate had gone all the way up to 120. Now, anxiety can cause heart rates to go up, and anytime someone's in the emergency room, you'd expect them to be a little nervous, but I wouldn't expect her heart rate to go up 40 points in an hour just from sitting in an ER waiting room and then coming to talk to me. So right off the bat, I was a little concerned about that. Secondly, her chest pain was not just chest pain. It was chest pain with flu-like symptoms. And that to me is a huge red flag. So her story wasn't that she just started having chest pain an hour ago. Her story was that she's had flu-like symptoms for the last couple days. She's had fever, cough, sore throat, poor appetite, muscle aches, and then she started having chest pain. And now she was having shortness of breath whenever she walked upstairs. She was having pain that was worse when she moved around. Those trigger red flags for me because I start to worry whether that flu virus or whatever virus caused her flu-like symptoms was starting to cause a complication called myocarditis. Viral myocarditis is a phenomenon and an infection where patients get a virus, a viral infection, that then actually infects the literal muscle in the heart. And it causes inflammation and consequence within that heart tissue that can be rapidly lethal if it's not diagnosed and treated. So anytime a patient comes into the emergency room with preceding flu-like symptoms, like in this young woman, fever, cough, sore throat, runny nose, muscle aches, and then ends up having chest pain, that immediately shoots to the top of my differential diagnosis as a don't miss diagnosis, because if I send someone home with myocarditis, they could die before they have the chance to see another doctor. The other hint that I talked a little bit about already that made me nervous is myocarditis is typically associated with fast heart rates. So the fact that she came into the emergency room with a heart rate in the 80s, and then by the time I saw her was all the way up at 120, that was another clue that, I really need to evaluate for this. We don't know the exact incidence of viral associated myocarditis, meaning that we don't know how often exactly this occurs, particularly with the flu. If you think about it, millions of the people in this country have flu every flu season, and not all those flu infections are actually reported to healthcare professionals. So we can guess how many flu cases there are per year, but realistically, we don't really know. And if we don't have that denominator, it's really hard to know what percentage of those flu cases end up developing myocarditis. There was one study that looked at patients admitted to the hospital with influenza or flu that found anywhere from about 2 to 3% of those patients developed acute myocarditis. If that means all the sickest patients, the ones who were admitted to the hospital, about 2 to 3 out of 100 developed myocarditis, we can assume that way fewer than 2% develop myocarditis from general flu infections, because if you think about it, most flu infections don't get admitted to the hospital. So how do you diagnose myocarditis in these patients? Well, first of all, in the emergency room, we can't really do the definitive test for myocarditis, which depends on who you ask, is either a gadolinium enhanced cardiac MRI or what's it called? Contrast, that's the word. Contrast enhanced cardiac MRI, which is an advanced imaging modality where you can literally see the inflammation in the heart light up because of this contrast. I can't do that in the ER. I'm just an ER doctor. And even if I could, our MRI machine, it has no availability in order to do that in the ER anyway. The other definitive diagnosis for acute myocarditis is actually a cardiac biopsy, where a surgeon will literally put a needle into the patient's heart muscle, take a little bit of that heart muscle out, and then a pathologist will look at that muscle under a microscope and make the diagnosis that there's lymphocytic infiltration or specific kinds of white blood cells that define the syndrome of acute myocarditis. I'm certainly not getting a gadolinium enhanced cardiac MRI in the emergency room, and I am certainly not putting a needle into someone's heart in the emergency room. So we do the best we can with proxy tests. And what that means is we'll send blood work to look for an elevation in a troponin. Troponin is a cardiac enzyme that's in all of the heart muscle cells. And when there's inflammation or damage to the heart muscle cells, it gets released into the blood. So when we do a blood test, we can see the troponin levels go up. And that's an indicator to me in the right patient, flu-like symptoms now with chest pain, that they probably have some kind of myocarditis going on. We'll also send off blood counts, white blood cell, red blood cell. We'll send off markers of inflammation, electrolytes. We'll send off something called a pro-BNP to see whether they have signs of congestive heart failure. Because the concern with myocarditis is not that the heart itself is inflamed. It's what happens to an inflamed heart. And there are a couple things that we worry about. The first is that when the heart's inflamed, it can go into what's called arrhythmias. The heart typically beats in a regular pattern, but if it's inflamed and infected, you might have irregular patterns of heartbeats called arrhythmias. that cause the heart to not beat effectively. And as you can imagine, a heart that isn't beating effectively is very unsafe. What's concerning about myocarditis is that you have a higher rate of what's called ventricular arrhythmias. Remember that the heart has 4 chambers, and the ventricles are the pumping chambers. If the pumping chambers, the ones that get blood out to your lungs and the rest of your body, are not doing their job, you are in trouble. So ventricular arrhythmias with acute myocarditis can be rapidly lethal. And that's something that we need to know about and we need to monitor for really closely. The other thing that can happen, instead of beating in an irregular pattern, the heart can beat more weakly than before. And that can lead to something called congestive heart failure. Simply put, congestive heart failure is when the heart doesn't beat blood out to your organs the way that it should, and it starts filling up and filling up and filling up with blood instead of pumping it out. It causes the heart muscle to get even weaker than before. It's Starling's law. We're not going to talk about it. And it means that the rest of your body isn't getting the blood that it needs. Bad, bad, bad. Because the final common pathway of both of these things, either ventricular arrhythmias or congestive heart failure, is shock and then death. So neither of those being great, we really try to diagnose myocarditis quickly and make sure that these patients are typically admitted to intensive care units where they can be monitored closely to make sure that they aren't developing some of these life-threatening emergencies. If a patient develops acute fulminant heart failure from viral myocarditis, or really any form of myocarditis or cardiomyopathy, they end up having to go on this really crazy circuit called a VA ECMO circuit. VA ECMO stands for veno-arterial extracorporeal membrane oxygenation. Say that 5 times fast. It's literally a machine that takes over pumping blood for your heart. And it is the last-ditch effort to keep people alive when their heart is infected and inflamed, like in acute myocarditis. And we really try to prevent patients from getting to that point. So early diagnosis and treatment in myocarditis is key. So what ended up happening with this patient in the emergency room is those blood troponins came back way, way, way elevated. Normally in our lab, a troponin level should be under 7. Hers was over 100, which for a young, healthy person is way too high. Unfortunately, an hour later when we rechecked it, it was still going up, which is another marker that we are up a creek without a paddle, if you will. And this patient needed to be emergently admitted to an intensive care unit. We also started seeing markers with the proBNP that the heart was filling up and expanding with too much blood rather than pumping effectively. And the patient was at high risk at developing one of those lethal outcomes. Thankfully, this patient didn't have a bad outcome. They were admitted to the intensive care unit. They were treated aggressively with intensive care protocols. And over the next couple of days, the infection went away, their heart muscle recovered, and they were eventually discharged from the hospital, thank God. However, they're going to need really close cardiology follow-up for potentially years in order to make sure that the heart recovers back to its regular baseline and keeps beating the way that it should, as strongly as it should, for as long as it should afterwards. So yeah, that was my week this week. It was a crazy week. We saw a ton of human metapneumovirus, this bad respiratory virus in kids that's like RSV that gets a lot of children admitted to the hospital. I had to tell someone they had meningitis. I had to tell someone that their heart was inflamed and needed to be admitted to an intensive care unit. Thankfully, everyone did fine. Everyone survived. Another week in the book, and I'll see you all next week. Thanks for watching.